Assalamualaikum. Let's begin our session with Ummul Kitab Al-Fatihah. Okay, so this is our second and last session on procedure, isn't it? So again, yes, this is unusual punya setting for us to do in this format. It's not ideal at all, but I think whatever we have, we'll just do our best. Okay. I've given the topics, and today is just the remainder of the procedures that I wanted you all to discuss. And let's proceed. Okay, tafadhal.
Okay. Okay. So now I will present about the umbilical lines with part 2 of center access. So in this procedure, there will be a short term that I use UVC and USC. So umbilical line is a procedure in which catheter is inserted into the one of the arteries and also the vein of the umbilical cord. Generally, this procedure is used in the neonatal intensive care units in order to get quick access of the central circulation. And then this is indication and contraindications for the USC. The indication is to do repeated blood sampling in ill newborn, especially those of ventilator. Second is occasionally it is used for continuous BP monitoring and infusions.
Kecil. Kau tukar slide
lah? Tukar.
Oh, okay. Kita tak gerak. Okay.
Okay.
Bawang nampak.
Okay. And then for the contraindication for USC is local vascular compromise in lower extremity, peritonitis, necrotizing enterocolitis, and omphalitis. And then for the UVC, umbilical vein catheterizations, the indication is UVC is used for venous access in neonatal resuscitation as a venous access in preterm babies, especially in extreme low birth weight babies less than 1 kilogram, and also in sick babies in shock with peripheral vasoconstriction. And then for the doing exchange transfusion for severe neonatal jaundice. And the contraindication for UVC is omphalitis, omphalocele, necrotizing enterocolitis, and peritonitis.
Okay, can I
to the equipment?
Okay, wait. Can I add something? So UVC basically is not just done in NICU, as you have mentioned. It's also done for neonatal resus. So neonatal resus is basically in the labor ward lah. So in the labor ward, so we do. And what else I want to add? Okay lah, I forgot another point that I wanted to say. Okay lah, alright, proceed.
Okay, doctor. And then this is the equipment for the umbilical line. First, USC and UVC set. And then second is umbilical artery and venous catheter, which need to do with appropriate size of the catheter, as you see in the table below. This is the size for USC and the size of UVC. And then the third one is 5cc syringe filled with heparin.
Brother, I don't know why your slides are not moving. It's still stuck at the indications and contraindication.
Oh, really?
Baru bergerak.
Okay.
Ada delay ke?
Delay. Okay. This is the equipment used for umbilical line. This is the 5 equipment that I mentioned before. 3 threadwear and FIDA line, as you can see in the picture. And usually in certain hospital setting, all of the equipment is already included in the USC or UVC set. And then this is the list in the UVC or USC set. Did the slide moving? Did the slide move?
Yes.
Yes.
Yeah. And then first of all, prior to the setting, we need to examine the infant's lower extremities and buttocks for any sign of vascular insufficiency. And then palpate femoral pulses for their presence and equality, and then evaluate the infant's leg, feet and toes for any asymmetry in color, visible bruising or vascular insufficiency. And the last one, document the finding for later comparison. Do not set if there is any sign of vascular insufficiency. And then this is the formula in which we need to measure for the catheter to be inserted according to the desired measurement. And then for the formula for USC is body weight in kilogram times 3 plus 9 plus thumb length in cm. Thumb is the remaining of the umbilical cord that attached to the abdomen of the infants. And then this is height position which is recommended, and otherly is low position which is no longer recommended. And then for the formula for insertion length of UBC, the question is 0.5 times USC in centimeter and plus 1 centimeter, or birth weight in kilogram times 1.5 and then plus 5.5 plus thumb length in centimeter. Then we move to the procedure. First, you can refer to the picture that I include in this slide. First, we need to hold the umbilical stump upright by grasping the water jelly before set, and then clean the abdomen and cord with bactericidal solution. For example, chlorhexidine, and then drap in sterile fashion so the cord is exposed. Just like the picture below, we need to cover the abdomen except for the umbilical stump, and then tie a piece of umbilical tape or nylon suture around the base of the umbilical cord tightly enough to minimize blood loss but loosely enough to insert the catheter so that it can pass easily to the vessel. And the fourth one, by using scalpel, cut cord about 1 to 2 centimeter above the abdomen to get a fresh view of the umbilical cord. And then the fifth step is stabilize the cord with forceps or hemostat and identify the vessel. And then how to identify the vessel, how to differentiate between the umbilical artery and the umbilical vein. First, we can see that usually the arteries will at the position at 4 and 8 o'clock. And for the umbilical vein, usually its position is at the 12 o'clock. For the arteries, it has thicker wall but smaller in diameter, and it's white in color and constricted. For the umbilical vein, has a thin wall and patellus, which is dilated vessel. And then when we withdraw the blood into the catheter, we can see a visible pulsation. And then the blood that is withdrawn into the catheter is bright red in color. And for the vein, we can see that the venous and the blood is dark red in color. As you can see in the picture, the umbilical vein is at 12 o'clock and the umbilical arteries are both at the 4 o'clock and also the 8 o'clock in position. And then the next step is to dilate the artery or vein if necessary by inserting tip of curved Aris forceps and allow spring to gently open the vessel. And then grasping the catheter with a forceps or between the thumb and forefinger, the catheter can be inserted into the lumen of the dilated artery or vein. Supporting the stump is usually necessary. And this I include the tips to get a successful catheterization. For the UVC, we need to tip the stump toward the stick the stump toward the feet, so that when we insert the catheter will be insert posteriorly and superiorly in the direction of the head or right atrium. If we do a USC, it will be the opposite of the UVC, in which in USC we need to insert the catheter posteriorly and inferiorly in the direction of the leg. This is according to the pathway of the vessel. And then as we already identified the vessel, we insert the catheter to the desired distance. And then last step is place purse string suture to stabilize catheter and tegaderm to abdomen in order to avoid accidental dislodgement. Now this is another picture for the step taken for catheterization. And then after the procedure, we is must to perform chest and abdominal radiograph to ascertain the tip of the catheter. For the USC, the desired placement of the tip is above diaphragm between T6 and T9 of vertebra for height position. For UVC, the placement of the tip we is at the in the inferior vena cava above the diaphragm. In the USC, after the procedure, we need to monitor the lower limb, buttocks area for ischemic change 2-4 hourly, and infuse heparin and saline continuous to the USC as list here. And then remove the USC as soon as no longer required to reduce the incidence of thrombus formation and long line sepsis. For the UVC, we need to consider to remove the UVC after 5 to 7 days to reduce the incidence of line sepsis or thrombus forming around the catheter. Sometimes in this procedure, the doctor can accidentally insert the catheter into the wrong vessel. So it is important to first identify the vessel which the catheter need to be inserted, so that we will not accidentally put in the wrong vessel. And then for the complications of the USC, just I have listed in here is a bleeding for accidental disconnection and open connection, embolization of blood clot or air in the infusion system. Third is vasospasm or thrombosis of aorta, iliac, femoral or obturator artery. And then thrombosis of the renal artery, vascular perforations of umbilical arteries, hematoma and retrograde arterial bleeding, and infections. And for the UVC, the complication is infections. The second is thromboembolic, lungs, liver, even systemic circulations. And third, pericardial tamponade, arrhythmia, and hydrothorax. And the last one is portal vein thrombosis and portal hypertension. So this is my reference.
Faizal, back.
Yeah.
Just show the complication slide again. Complication. Okay, I just wanted to say that these complications are real complications. I think, was it last month? Last month we have a patient, a premature baby, who bled from the UAC. So, and the hemoglobin dropped from 16 to 10. So it's a 5 grams or 1/3 of hemoglobin dropped. So that is a very significant loss of blood. And then we've seen cases where there's air embolization as well. I have seen cases where the patient developed portal vein thrombosis. There are cases, one of the cases that I handled was the junior doctor accidentally, when trying to remove the UVC, So the junior doctor accidentally cut the UVC. So what happened was because of pressure, and then the tip, because they accidentally cut the tip of the UVC. So the tip of the UVC then went inside the liver. So it dislodged the distal part of the liver. So was seen by a vascular surgeon, and the decision was to just keep it there because the risk of bleeding and things from surgery is higher. But there is a risk of the child to develop portal vein thrombosis later on. So all these are serious punya complications. Infection as well. So infection, because you're going to access this line very frequently for UAC, you're going to take blood from it, you're going to access it very frequently, and this is a very huge vein direct straight to the huge vein, straight to the heart and straight to other organs. So it's a very high risk of infection. UVC, I just wanted to highlight to you, UVC is the easiest access for vein in newborn. You know, sometimes in newborn, especially those newborns who are born with, whose delivery are complicated by placental abruption, for example, kan. Placental abruption ni maknanya ada bleeding, ada antepartum hemorrhage, for example. So mother ada loss of blood, so baby pun boleh loss of blood as well, antenatal liver. So this sort of baby sometimes they are born in shock. So sometimes getting a good vein is very difficult. So umbilical vein is the easiest access. You just put in, you can just put low UVC first for during resuscitation. Just put it in. Kalau you tak ada, sometimes in certain smaller hospital, smaller district hospital, you don't have proper umbilical catheter. So you can just use rice tube. Just masukkan rice tube dalam tu. So it's a very easy access. But this is only for newborn. Sebab by 10 days dia dah tak ada dah, kan? By 5 days dia dah keras dah. So you cannot insert anything inside it. So for newborn, this is the easiest access, easiest vascular access. Okay, alright. Any question to the presenter? Aku yang goreng panjang ni. Okay, next.
Assalamualaikum. I am Nur Shafatin. I will present about chest drain. So this is the outline of my presentation. For introduction, chest drain is a common procedure in which any tube or small catheter is placed through the chest wall into the pleural cavity and used primarily to drain air or fluid. So the indication for chest insertion including pneumothorax, hemothorax, empyema, pleural effusion, also pleurodesis and some other indication. So pleurodesis, it is a chest tube insertion to facilitate the instillation of sclerosing agents into pleural space for treatment of refractory effusion. So for a contraindication of a chest drain, including anticoagulation, coagulopathy, overlying infection, and also bleeding diathesis. So as for the preparation, first of all, we need to obtain history and examination prior to insertion of the chest tube. So we need to know if the patient has cardiomegaly, situs inversus. So situs inversus is a condition in which the arrangement of the internal organs is a mirror image of normal anatomy, as you can see here. Next, if the patient has mediastinal tumor, prior thoracic surgery, prior chest tube placement or pleurodesis, presence of medical devices such as central venous access or port, pacemaker or defibrillator, if the patient has bleeding diathesis, tendency to bleed or bruise easily, antithrombotic therapy, or if the patient is obese, has scoliosis or any chest wall deformity. Other than that, we also need to obtain if there is any factors that elevate the diaphragm, such as radial lembut position, hemoperitoneum, and stomach or intestine from positive pressure ventilation, bowel obstruction, or even obesity. And other factors in the pediatric population include diaphragm integrity, whether it is congenital or traumatic, functionality, and height, which may fluctuate significantly with phases of breathing, which may be quite rapid, or from crying, hyperventilation, or anomalies such as tracheoesophageal fistula. Other than that, cysts, pulmonary abnormalities, or congenital malformations that mimic pneumothorax on radiograph, also developing breast tissue in prepubescent females. So prior to chest tube insertion, penetrating trauma and also elective thoracic operations warrant need antibiotic prophylaxis, but not a spontaneous pneumothorax, because based on study, 25% patients develop some induration around the entry site of chest tube, but it is settled without further treatment, meaning that we don't need antibiotic prophylaxis. For tube selection, silicone or PVC tubes that have a radiopaque strip with a gap that serves to mark the most proximal drainage hole. So silicate or silicone chest tube are preferred over older latex rubber because older latex rubber have fewer drainage holes, is not well seen on chest radiograph, produce more pleural inflammation, and may have been associated with latex allergy. So there are straight and angled thoracostomy tube. Usually angled thoracostomy tube are often used in the surgical setting to assure the placement in posterior costophrenic sulcus. Chest tubes are available in a wide range of French sizes and are sized based upon the weight of the patient and the indication for placement. So if we want to know the diameter of the tube in millimeter, we need to divide the diameter in French by 3. So for pediatric chest tube size, general rule of thumb is the estimated uncuffed endotracheal tube size times 3, where this uncuffed endotracheal tube size is estimated from formula 4 plus H divided by 4. However, according to PICS protocol, if the patient has below 2 kilogram body weight, we use a chest tube with 8 French size, while in infants, 10 French for if the body weight is more than 2 kilogram, and for all the children, they can be inserted with 12 to 18 French size tube size. As for positioning, supine position for children with 30-degree head of bed elevation to allow for decreased height of diaphragm in children, or even sitting position for those suspected of having a high diaphragm. Also, you can consider a nasogastric tube for air aspiration from the stomach in a child to lower the height of the diaphragm. For analgesia, in emergency clinical setting, the chest tube can readily be inserted under local anesthesia, for example, 1% lidocaine. In elective setting, we can use oral or intranasal or IV sedation can be administered prior to tube insertion, plus local anesthetic infiltration. For non-critically ill pediatric patients, they may require additional distraction techniques, emotional supports, or medications to help with anxiety. For insertion site, usually most clinicians they incise at the 4th or 5th intercostal space in the anterior axillary or mid-axillary line. In emergency situation, the landmarks are the nipple line in males and the inframammary crease in females. For elective chest insertion, especially to drain effusion, it may be placed 1 to 2 rib spaces lower or as low as possible in the chest with the use of ultrasound guidance. As As for the technique, this is the equipment list for tube thoracostomy, including lidocaine, needles and syringe, scalpel, clamps, scissors, chest tube, suture, sterile drapes, gown and gloves, and a drainage system. So for technique, there are two, which are tube thoracostomy and also needle thoracostomy. Under tube thoracostomy, there are two techniques, which are standard technique and also Seldinger technique. Standard technique usually is used to drain effusion or hemothorax, and is more typically done in older adolescent or in adult. For Seldinger technique, it's mainly used to drain air or non-viscous fluid. However, the disadvantage for Seldinger technique is that we cannot assess for adhesion between lung and pleural surface during insertion. So for the standard technique, firstly, we need to sedate the child, position the child, clean and drape the skin, infiltrate the local anesthesia at 4th or 5th intercostal space on mid-axillary line at the triangle of safety. Next, we need to check approximate length of the tube to be inserted as it follows the curve of the chest. So the tip of the tube should be at the highest point of the chest in a patient with pneumothorax and lowest dependent chest if the patient has pleural effusion. So for upper method, we need to make small incision in the skin just above the 5th rib. Use blind forceps to dissect through the subcutaneous tissue and puncture the parietal pleura with the tip of clamp forceps. And then we put a gloved finger into the incision and clear the path into the pleura. Then we advance the chest tube into the pleural space during expiration. So for drainage of air, we should roll the child slightly to the opposite side for easier maneuvering and advancement of the chest tube anteriorly. So place the tube of the chest tube at the incision, point the catheter tip interiorly and slowly advance the chest tube. However, for drainage of empyema, maintain the child in supine position and point the catheter tip posteriorly. Then we connect the chest tube to the underwater seal. The water should bubble if pneumothorax and the fluid moves with respiration if chest tube is in the pleural space. Then we secure the chest tube with suture in children or sterile tape strips in neonates. Connect the underwater seal to suction pump if necessary for empyema, and then confirm the position with chest X-ray. So this is a video on standard technique.
The most important landmark in the patient is the nipple. The nipple signifies roughly the 4th interthoracic space, at which point the chest tube is then placed in the anterior axillary line, just lateral to the nipple, but at the same level.
Sorry.
The most important landmark in the patient, just lateral to the nipple, but at the same level, to ensure on the patient, thereby violating the diaphragm and placing the chest tube inadvertently into the peritoneal cavity. Again, we appropriately identify the nipple, come across to the anterior axillary line laterally on the affected side, at which point we then will place the chest tube through that rib space and into the pleural space. With the patient appropriately prepped and draped, prior to doing the procedure, we confirm one last time the reason why the procedure is being done and confirm the side that the procedure needs to be done on, in this case is left chest. We then confirm our anatomical landmarks, which is the nipple and anterior axillary line, which should represent either the 4th or the 5th interspace where the chest tube will be placed. We palpate the ribs in that area, and we will then make the incision, tunnel in above that incision, just above the rib. We will then bluntly dissect into the pleural space, holding the position with the clamp, after which point the tube will then be placed through the clamp into the pleural space. Ideally, once the patient has been appropriately again prepped, draped, and anesthetized, confirm placement, we then document the placement of the nipple at the junction of the anterior axillary line on the affected side. We then make an incision below the affected rib space. The incision needs to be large enough not only to accept the chest tube, but also to accept the clamp for the dissection into the chest cavity itself. The incision is made with any sharp knife that is then placed off the field so as not to inadvertently injure the operator or the assistants. You then take the blunt instrument, you then find your affected rib space, you then gently dissect in directly over the rib cephalad to where you are, thereby confirming the location. You then dissect into the pleural space. Once you have adequate entrance into the pleural space, the clamp is left in as a bookmark, if you would, to guide the passage of the chest tube, which is in place through the clamp itself, and then into the patient. Sometimes the chest tube will be assisted by placing the clamp around the tube to help guide it through the ribs and into the pleural space. Once the chest tube has been adequately placed, it then needs to be secured in a proper position with the placement of a suture in and around a single Roman stitch on the skin, and then have a stitch.
An occlusive dressing is then placed over the site of chest tube insertion.
Once the tube has been placed in the proper location and secured in place, we then take a male-to-male connector so that we can connect the chest tube output to our collection device to collect both air and blood. Once the tubes have been placed via the connector, the tube is then ensured to be in adequate position with no evidence of leakage of air or fluid around the tube and secured in place. Device whereby our negative pressure is conducted.
So the next tracheostomy technique is Seldinger technique.
We're going to be presented with when we're looking at a Seldinger chest drain. So if we just open it and go through each bit in turn. And it's wise to check through your kit before you do any procedure, just to make sure you're familiar with everything. So piece by piece, we've got the scalpel for the skin incision.
Seldinger teknik ni macam pigtail lah.
We introduce a needle, the wire's going to be fed along.
Okay,
And we've got the syringe that attaches to. Got the guide wire that we're going to be placing down the introducer needle. The bevel on the end will unscrew, and then the wire different size, and they've got little stops, varying thickness wire, and that will unscrew. We've got the end teat, which is screwed on arcs and coming down to the right intercostal space. Going to clean and infiltrate with lignocaine. Then we're going to make an incision in the skin. Not as big as for an open chest drain. Okay. Then going to get our introducer needle and our syringe. Okay, and we're going to aim this into the chest through that incision, aspirating as we go until we find we're in pleural space. Disconnecting the syringe, holding onto the needle. Okay, then going to get our guide wire, place that in, and advance that. Okay, keep your hand on the guide wire all the time. Take the needle out. Get rid of that. And we'll take the introducer. Okay, take that back out. Go to the next dilator. Pick that up. And finally the biggest dilator. And dilate the hole to the biggest maximum diameter. Okay. Then we get our drain, which has still got the stylet coming down the middle of it. I'm going to advance this until all the eyelets are actually in. So again, advancing that through, making sure that don't let go the guide wire. Okay, and then when it's come out the other end of the tube, hold on to that firmly and advance the drain down the tract you've just created. Okay. Then take the guide wire out. You can then unscrew the stylet from the drain. Taking that out, down the tube when you do that. Attach your three-way tap, closing the drain off for the moment.
Okay, other than tube thoracostomy, there is a needle thoracostomy. But we perform on the affected site in the mid-clavicular line through the second intercostal space or at the fifth intercostal space mid-axillary line with one of any readily available kits, whether a long angio catheter or the introducer needle for a pigtail catheter. So needle thoracostomy is indicated in tension pneumothorax that must be decompressed before chest tube insertion. It is done under strict aseptic technique where we attach a 10 ml syringe already filled with 2 ml thermal line to a gauge angio catheter. Gently insert the catheter perpendicularly through second intercostal space over the top of the rib at the mid-clavicular line while applying a small negative pressure as the needle is advanced. So air will be aspirated through a successful needle thoracosynthesis. When this happens, remove the syringe and needle while leaving the catheter in situ to allow the tension pneumothorax to decompress. Then insert chest tube as soon as feasible. So this is the chest drain system, multifunction chest drain. It has three compartments, which is a drainage chamber, water seal chamber, and also suction control. Other than that, we also have this chest drainage bottle. It can be the single bottle, which we call underwater seal chamber, or a double bottle, which we call as trap bottle, and also when there is three bottle, it is called as suction regulator chamber.
Why is the underwater seal is important?
Underwater seal is important to prevent the re-entry of air into the lung.
Okay, so the water actually creates a barrier so that air can go out but cannot come in because of the water and surface tension with atmosphere and things. Okay, all right, good.
For removal criteria for pneumothorax, we can remove when the lung is fully expanded and no visible air leak is present and air does not accumulate when suction is removed. For effusion, when the lung is adequately expanded, when the majority of empyema has been drained and the patient is doing well. Daily fluid output is less than 100 to 300 ml a day in adult and likely less for pediatric population. So for the technique to remove, we should explain the technique that will be used to the patient. So the patient should rehearse this several times prior to the actual tube removal. Also ensure that the suture has been removed prior to removing the tube. To remove the tube, hold the dressing near the chest tube insertion site with the non-dominant hand. Ask the patient to perform the planned technique and verbally reinforce it. Remove the chest tube quickly with the dominant hand while placing a dry sterile dressing. Secure the dressing with tape and obtain a chest radiograph to evaluate for recurrence of pneumothorax or accumulation of fluid. There are several complications of chest tube insertion, including the most common complication, chest tube malposition. This may represent a form of penetrating trauma. So, doctor in charge should consult with a pulmonary or thoracic surgery service for solution, such as if intraparenchymal chest tube should not be removed until a second functioning chest tube has been placed into the pleural space. Other than that, complications include infection, whereby in about 1 to 3% of chest tube inserted patient, they can develop pneumonia and empyema. So the risk of infection include increased duration of chest tube placement and retained hemothorax, which more common in patients sustaining penetrating chest trauma. Other than that, organ injury could also occur, which most commonly lung affected, other than heart, spleen, liver, stomach, colon, and diaphragm. And a last complication in this list is re-expansion pulmonary edema. It is uncommon but potentially life-threatening. It usually arises after rapid re-expansion of a lung that has been collapsed due to either pneumothorax or effusion for at least 3 days. So patient developing edema typically present soon after chest tube placement with cough, dyspnea, and hypoxemia, but the clinical presentation can be delayed for up to 2 days. So suggestion for prevention is to avoid suction for expansion of spontaneous pneumothorax and limiting initial fluid drainage. The treatment is supportive, including positioning, positive pressure ventilation, fluid restriction, and the disease is usually self-limited. These are my references.
Okay, good. Any question?
Nak tanya yang Seldinger technique, which site that we introduce the needle insertion?
It can can be similar to the standard technique at the 4th or 5th mid-axillary line at the safe triangle.
Yang dalam video ni kat mana?
Dalam video.
We're going to be presented with, we're looking at a teat. We're going to make an
Oh,
incision.
ini kan. Tak tahu lah kat mana sebab dia punya.
Not as big as for an open chest drain.
Okay.
I'm going to get our introducer needle.
The insertion site is just the same.
Basically, Seldinger technique is very safe. It's very easy because you're using just needle and then you introduce with the guide wire and then you put the catheter in. So it's much safer daripada yang the other technique tu. The other technique pun dia ada dua, dia ada open technique and also closed technique. So closed technique ni, blind technique ni orang tak buat dah sekarang ni lah. So basically blind is you just make a small incision dekat skin dia and then you push and give counter pressure. Some people still use this technique, but this technique is very dangerous, very high risk of you injuring the other organs. So the ideally now you use an open technique, the one that you saw. So kita buka sampai kita nampak dia punya pleura dan kita puncture the pleura, kita masukkan. Tapi the problem with this technique, sometimes you can increase more pneumothorax while you're doing it. Okay, alright.
Any other question?
No.
Stop share.
Okay, who's the next presenter?
Hello. Okay. Assalamualaikum and a very good evening. I bid to Dr. Syed and my fellow friends. So I will be continuing our procedure presentation with procedure of lumbar puncture. Sekejap ya. Okay. My name is Fatin Nuzul Najwa binti Saini. So before we go into the core of the lumbar puncture, which is the puncture, so let us first briefly revise the anatomy of the spine and also the spinal cord. Okay, now this is our vertebral column, which includes 7 cervical, 12 thoracic, 5 lumbar, and 1 sacrum and 1 coccyx. Now, depending on which vertebral bodies, the bones differ according to their physical appearance. So you can see at the right side. Now, okay. So at birth, when we were born, the termination of our spinal cord, or also known as the conus medullaris, it ends at L3. However, as we grow, our vertebral column also grows, and hence it causes our spinal cord to be at the level of L1 and L2. Okay. So that is why in adult, the conus medullaris is between L1 and L2. Okay, now when we do lumbar puncture, we will come across these 3 types of ligament, which are the supraspinous ligament, interspinous ligament, ligamentum, and ligamentum flavum. Now, the interspinous ligament is the ligament that we will go through, and afterward we will come in contact with the ligamentum flavum, which is the thickest ligament. Hence, why in lumbar puncture, the clinicians who do the LP can feel a pop as the needle go through the ligamentum flavum and into the subarachnoid space. Now, we also know that the spinal cord, it is in the subarachnoid space, and it is bathed in the cerebrospinal fluid, which is what we are attempting to extract from this procedure. Okay. Now, typically in pediatric, generally, the site where lumbar puncture is done would be below L2, which is safe, because we know that the tip, inferior tip, ends at the L1 and L2. Hence why we chose to do lumbar puncture below L2. So it can be either L3, L4, L4, L5, and so on. So how do clinicians identify where to do the puncture site? Now, may I direct your attention to the bottom picture. Now, how to do it is, first we identify the posterior superior iliac crest, the bony prominence, and then we connect these 2 crests with an imaginary line. Now, this imaginary line, it crosses approximately at L4. So below the L4, we can find the L4, L5 interspace. Now this is where we can do the lumbar puncture. Okay, now, okay. The indications for lumbar puncture include, first, in patients that we suspect to be having a CNS infection, either meningitis or encephalitis. Next one, in patients suspected to be having subarachnoid hemorrhage. And other than that, lumbar puncture is also diagnostic and therapeutic for certain kind of diseases such as intracranial hypertension, certain malignancies, seizures, metabolic disorders such as disorder of GABA metabolism, and also neurological conditions such as Guillain-Barré syndrome. Okay, now this is the contraindication in which we should pay attention to.
Don't forget for malignancy. So sometimes you do need to do. Oh, ada certain malignancy. Okay, fine. Alright. Tak nampak tadi. Okay, fine. Proceed.
Okay, now for the contraindication. The first contraindication would be high intracranial pressure. Now we have been exposed that if there is high intracranial pressure and we do proceed with lumbar puncture, the patient will be at risk of having cerebral herniation because when we do lumbar puncture, there will be a lower pressure at the caudal area, causing a shift of the intracranial contents. Now, the second contraindication would be respiratory distress, in which the patient would be at risk of having hypoxemia or apnea during the procedure, which is very concerning, very dangerous. Now, the next one would be hemodynamic instability, such as shock. Now, this is why. Okay, tak apa, nanti lepas. Okay, the fourth contraindication would be soft tissue infection at puncture site. For example, cellulitis or epidural abscess, as this is a contraindication because if we do proceed with lumbar puncture, even if there's infected puncture site, the patient will be at risk of developing complications such as bacterial meningitis or infection. Okay, the fourth contraindication would be bleeding disorders, and the patient that is categorized under this class is one that have platelets level of less than 50,000 per millimeter cube, patient that has INR of more than 1.4, patient with active bleeding and has coagulation defect. Now, before proceeding to doing LP, we should first correct these bleeding disorders. Okay, now the last contraindication would be coma. Okay. Okay, now for preparation, the first one, before doing any LP, we should first evaluate whether the patient is fit or not for the procedure. Now, this is where the contraindication comes into place. So if the patient has history of physical findings suggestive of high intracranial pressure, we should delay LP and instead proceed with neuroimaging. And for patients who have sign of infection, we must first resolve it first. Okay, yes. And after evaluating and we see that the patient is suitable for a lumbar puncture, we should proceed with counseling the patient and also the parents. Now, we are very well aware that in our society, the Malay, there is a stigma surrounding us in which if we do LP, we will be paralyzed afterwards. So that is absolutely not correct. So we have to give clear explanation to the patient and clarify that the myth that's going on, it is a myth. Okay, and also aside from that, we should also get written consent and not just the verbal consent. Okay, now these are the equipments for lumbar puncture. Lumbar puncture, which includes anesthesia, either lidocaine or topical anesthetic cream, and then syringe with needle, 4 sterile collecting tube, our own personal protective equipment, cleaning solution, sterile sponges to use the cleaning solution, sterile drape, manometer, but this manometer is not usually used. Okay, next one would be spinal needle with stylet, and we may want to prepare an resuscitation equipment in case the patient develop any emergency during the procedure. Okay, now this is the procedure for the lumbar puncture. I will briefly explain it, and then I will show a video so you can better visualize and illustrate how the lumbar puncture is done. So for the first one, after having all the equipment and consent, we should first position the patient. Okay. Now the positioning can be done either in a lateral recumbent or a sitting position. Now in lateral recumbent position, the knees of the child are drawn upward towards the chest and the neck are flexed. Now this is to ensure that there is that the interlaminar space is opened up. Okay, now you can see that the assistant is holding onto the back of the neck and knees. Now, okay, now for the sitting position, it is preferable to be done in older children because they have more self-restraint and can be controlled. However, if we have to do it in an infant, the assistant has to grasp one arm and one leg in each of the hand and then support the head. For older child, they can just sit over the table with their legs hanging over it, and they have to be flexed over a pillow with their elbows resting on knees. Now be sure that during the procedure to always monitor the patient, the child, in case there is compromise in their respiration. So after positioning the patient, we then identify the interspaces in which the lumbar puncture will be done, as I've mentioned earlier how to do it. So the interspaces are either L3 to L4 or L4, L5. Okay, after identifying, we mark the site to make it easier for us when we come back. And then we clean the puncture site in circular motion, expanding the motion to cover more area, including the above and below side, and also the crest. And then after cleaning, we place a drape underneath the patient and use a drape with eye hole over the patient to visualize the puncture site. Then afterward, we can give anesthesia using either infiltrative lidocaine or topical ointment. Now, anesthesia, it is not usually given. Typically, it's not given. Okay. However, in infants, we can give oral sucrose because the sweetness provides a rapid relief of pain. And after anesthetizing, we would want to puncture the site now. However, first we have to make sure that the stylet is firmly placed inside the needle. And then afterward, we place the stylated needle in the midline of interspaces. And as we push the needle, we have to advance the needle towards the umbilicus so that we won't hit any bones if we go straight. Okay, now as we advance, be sure to remove the stylet from time to time to look for any cerebrospinal fluid flowing out. So when we see there is CSF flowing out, so it can either be clear or turbid or sometimes bloody. Okay, we can attach a manometer to measure the opening pressure. Okay, now I'll go through briefly the opening pressure. Now, the opening pressure is unreliable in patients that is younger than 2 years old, in patients who are struggling or uncooperative, and in patients that are in sitting position. Now, the normal opening pressure would be 5 to 20 centimeter H2O. Okay, after we have record the opening pressure, we then proceed with collecting the CSF in 4 collecting tubes. Now the first tube, the first tube would be for gram stain and bacterial culture. Second would be CSF glucose and protein. Third one would be CSF cell count and differentiation, and the fourth one would be for viral or fungal culture or other special chemistries. Okay, after collecting the CSF, we then replace the stylet, remove the needle, and then we apply adhesive bandage to the puncture site. So now that we've gotten a gist of it, let's watch a video.
Pediatric clinical skills from teatscases.com.
Can you see the video? Oh no. Oh, cannot. Okay, no. Okay. How to do? Okay. Set now.
Share the screen.
Okay.
For the video.
Okay, can you see the YouTube? Okay.
Yes.
And Stollery Children's Hospital.
Can you hear the sound?
This video
Yes.
will introduce
Okay.
you to lumbar puncture, an important clinical skill in pediatric medicine, the hemlock. Landmarking is important both for the application of the anesthetic and for performing the procedure itself. We'll review it now. Identify the iliac crest on each side of the infant. Place one finger on each crest and trace your fingers together across an imaginary line. This will lead you to the site of the puncture in the midline, at about the L3 or L4 level. This is below the end of the spinal cord. You may find it helpful to hold a finger of your non-dominant hand at that space to mark the spot. This will also allow you to feel if the child is rotating away from you. Positioning of the infant is critical for a successful lumbar puncture. You need a good helper to position and hold the infant. Your assistant should be experienced and should respond to your feedback about positioning. The helper will hold the hips and shoulders, curling the child in a position to open up the interspinous process. Infant lumbar punctures are typically not sedated, so the infant must be firmly held. Many helpers tend to curl the baby away from you, rolling their spine upward. However, it is essential that the length of the baby's spinal cord is parallel to the table. Remember, the right alignment is critical. Also note, lumbar puncture can be done with the patient sitting up and curled forward. This is more commonly done in older adolescent patients. This is not shown in the video. Cleaning of the site should be performed in a circular motion, working from the inside out. Clean well beyond the area you will drape with chlorhexidine and betadine. Do this 3 times. The baby's diaper should be off by this point. Place your drape so as to create an opening through which everything is sterile. There are a number of different ways to drape the child. One is shown here. And obtain the cerebrospinal fluid. Remember that your needle must have a stylet in. The stylet needs to be in, or else tissue can be pushed into the spinal canal. This can cause a devastating local reaction. Make sure that you are comfortable. Many people prefer to be sitting during. Stabilize your dominant hand on the baby's sacrum and aim towards the umbilicus. You should aim towards the umbilicus so that you can pass between the spinous processes. If you go in perpendicular to the skin, you are much more likely to hit bone, as you can see in this model. As you move the needle in, you may or may not feel a change in resistance, often called a pop. If you're not sure if there has been a change in resistance, periodically take the stylet out and see if there is CSF flow. If you cannot get flow, put the stylet back in and go a bit further. We check periodically. Once you have flow, collect the fluid in 3 to 4 tubes. If you can, get about 1 centimeter in each tube. Reinsert the stylet, take the needle out, and put pressure on the site with gauze. You can then dispose of sharps. Put a band-aid on and tell the patient and their family that the child should remain supine for at least 30 minutes to minimize the potential post-cap headache.
Okay. Can you see my slide? Oh no. Cannot see slide. Share. Can you see slide? Okay. Okay. So we've done with the procedure. We've collected all the CSF fluid and opening pressure. Okay. So this is the more detailed version of the procedure. So you can read it afterwards. Okay, now troubleshooting. So during the procedure, we may encounter some difficulties such as bony resistance. Now, these are the methods on how to navigate our way through the resistance. And if the CSF has a poor flow, we can improve it by first asking the patient to cough or do Valsalva maneuver. Or if the child is young, so they usually cry, and when they cry, the CSF flow will be much faster. And there may also be traumatic puncture in which the CSF becomes bloody due to the needle striking the venous plexus that encircles the spinal cord. Now, when this happens, if there is bloody fluid clot or the blood does not clear, we need to reattempt with a new needle and at a different site. Now, this is the CSF analysis, which I am pretty sure all of us know how to interpret. The glucose in the CSF analysis is in relation to our serum glucose. Hence why it is important that we do a random blood sugar prior to lumbar puncture. See here. Okay. Now, for the complications, the most common complications in lumbar puncture would be failure of lumbar puncture itself. Okay, aside from that, the second one would be the post-lumbar puncture headache, and the third one would be a localized backache. However, if the backache prolongs, there should be high suspicion of the patient developing localized infection or spinal hematoma. Now, for the rarer complication, it does happen. The first one is spinal hematoma. This is a complication that happens when the bleeding disorder is uncorrected. However, there are some cases in which the spinal hematoma happens in patients with no risk of bleeding disorder. Now, the clinical, the symptom would be back pain with neurologic findings such as weakness. The second rare complication is the nerve root damage. The next one would be the epidermoid spinal cord tumor. Now, this is believed to be due to epidermis or dermis tissue that is transplanted into the subarachnoid space, because it can be either due to the lumbar puncture being done without the stylet or with a loose fitted stylet. The next one would be the infection. Now, this happens when the site of the lumbar puncture is infected. And the last rare complication would be the cerebral herniation. It happens when the LP is done in patient with increased ICP. These are my references. Is that a question?
Okay, any question to the presenter? Any questions? Clear? Happy? So boleh counsel parents?
InsyaAllah.
Alright, next. Berapa lagi? Berapa presenter lagi?
Satu lagi. Satu lagi ada.
Okay, let's proceed.
For the next procedure presentation is about nebulization. So basically, nebulization involved in the respiratory system. You can see the particle following into the respiratory system up to the alveoli. And then nebulizer actually is a machine that converts the liquid medication into the fine mist, so that can be inhaled by the patient. So how the fine mist is produced, basically it produced by the compressed air through the liquid medication. So it turns the liquid into the mist form. So it can be placed, inhaled, either face mask or mouthpiece. So basically, nebulization nebulizer work by the principle of Bernoulli principle, whereby when there is a pressurized flow air that being directed into a constricted orifice, so the velocity of the airflow is increased and create like a jet stream. And then when the jet stream, when there's a jet stream over here, it creates like a sub-atmospheric pressure zone that can attract the fluid and form the aerosol particle. So this is the component of the nebulizer. We have the machine or chamber, face mask or mouthpiece, and the tubing. So basically, the oxygen flow is about 6 to 8 liter per minute. So this is a difference. Either you can use mouthpiece or face mask in nebulizer. So what make it different? Mouthpiece, usually we will see that there will be no leakage and no deposition in the nasal passage of face. For example, like in steroid, in anticholinergic can exacerbation of the glaucoma if the medication deposited into the eye. Other than that, advantage for mouthpiece, it can be efficient drug delivery. However, in face mask, usually it can easily used for the patient, especially in infants, young children, and in emergency. For the cons or disadvantage of face mask is the drug can be deposited in the nasal or the face. So, what medication or solution can be used in nebulization? So basically, example of medication include bronchodilator like beta-2 agonists such as salbutamol, or anticholinergic like ipratropium. So the action of this medication can use in to dilate the obstructive airway, for example like asthma or bronchitis. Antimicrobial if infection presence in the respiratory system. Adrenaline also can be used to improve respiratory distress, like improve glucocorticoid that have the anti-inflammatory action can actually reduce the anti-inflammatory inflammation.
Antimicrobial, eh?
Yes.
Can you name one situation where we give nebulized antibiotic?
As far as I know, example of antimicrobial like ribavirin that being used in RSV, but I'm not sure that is it common or uncommon.
For example, it's actually colistin. Colistin we use for cystic fibrosis. Cystic fibrosis. Okay, that's one thing. The other thing is nebulized adrenaline. Other than crude, we can also use for post-extubation stridor. Apa nama subglottic stenosis post-extubation. Sometimes we can give nebulized adrenaline as well. Okay, alright. Proceed.
Other than for as the glucocorticoid have anti-inflammatory action, it can actually reduce the inflammation and reduce the swelling, for example in asthma. So other than that, hypertonic saline or recombinant humidoranus alpha can be used to decrease viscosity of the sputum and increase its clearance, for example in cystic fibrosis. So basically, in nebulizer, it takes about 5 to 10 minutes to deliver the medication. And for effective nebulization, the drugs must be in 4 milliliter, and usually there will be a mix with the normal saline. So for indication, basically the aerosol therapy or the nebulizer is used in patients who are too ill or too young to handle this device, whereby a large drug doses are necessary. So, for example, like in acute asthma attack, respiratory distress, stridor, before physiotherapy, basically because cystic fibrosis, usually one of the management if we have to do physiotherapy. So before doing the physiotherapy, we have to loosen the secretion first. Other than that, drugs that is not available in inhaler preparation can also be used in nebulization, as well as large dose of nebulized antibiotic. So for limitation in nebulization, basically the limitation is due to the side effect of the medication itself. Like for example, in high dose salbutamol, it can have patient that tremor, tachycardia, hypokalemia, hypoglycemia, prolongation of QT interval, and administration of bronchodilator in hypoxic also can lead to pulmonary venous stenting and exacerbate the hypoxia. And same goes to the ipratropium bromide, which is the anticholinergic. It can worsen the narrow angle glaucoma, as I already mentioned just now, especially if they use the mask instead of, they use the face mask instead of mouthpiece. And then high dose nebulized corticosteroid can cause cataract formation and systemic side effects. So I provide the video regarding nebulization. Sorry. Okay.
Mana video kan? Cari video.
Huh?
Okey dah.
Cannot see the video.
Sorry?
Cannot see the video.
Cannot see. Oh, cannot. Oh.
Just
Okay.
Susah teknologi Pening
Boleh ke nampak?
Nampak?
okay, okay.
Boleh.
Boleh buat running commentary kot. Tak dengar audio.
Sorry?
No sound.
No sound. Audio tak ada.
Yes.
Sorry. Sorry nak buat sampah. Okay, sekejap. Boleh. Okay, sorry.
We'll also want to ensure the patient is in the correct position. I'm going to put the head of the
Okay dah. Alright.
To approximately 30 to 45 degrees. An important performance note. Before we proceed, we'll also want to ensure that the patient is in the correct position. I'm going to put the head of the bed to approximately 30 to 45 degrees. An important performance note about jet nebulizers is that they should be oriented approximately vertically to work effectively. Tilting the device too far, perhaps 20 to 30 degrees on any angle, in any direction, can cause the medication to move away from the jet gas port inside the device and render the treatment ineffective. If you notice a treatment you are administering is taking a long period of time, or there doesn't appear to be an appropriate volume of aerosol generated, you may want to check the nebulizer to ensure proper vertical orientation. Next, I'm going to connect the nebulizer to our gas source using oxygen tubing. It should be noted that in order to adequately power jet nebulizers, a specific gas flow is required for this device. The manufacturer in this case recommends 9 liters per minute. However, it doesn't necessarily matter what type of gas. It could be 100% O2, air, heliox, etc. You'll need to exercise good clinical judgment to determine the appropriate gas for your treatment. Often, patients receive 100% oxygen if there are no contraindications, simply because this is the most readily available compressed gas in most institutions. But importantly, make sure that the gas flow is not running when you connect it. You should wait until the setup is complete and the device is adequately affixed to the child before you start the gas flow. This will minimize the amount of wasted drug and maximize the received dose. Next, I have our drug. I've removed the cap and I'm going to take our medication, which is in a liquid suspension, and place it inside the device. We're going to replace the cap, attach the interface, affix the oxygen tubing to the bottom portion of the nebulizer, and place the mask on our patient. I'm going to turn the oxygen flow rate onto 9 liters per minute as per recommendations by the manufacturer. This treatment should last anywhere from 10 to 20 minutes.
Okay. Next, I'm going to share, as we already see the video, so it is this slide is regarding about how to use the nebulizer. First of all, we have to identify the patient and check the physician instruction to ensure that this is the right procedure to be done on the right patient, and then monitor the heart rate before and after the treatment for the patient using bronchodilator drug, because some of drug that I already mentioned just now, it can cause tachycardia, palpitation, nausea, and others. So we have to explain the procedure to the patient to ensure that patient is fully cooperative and to maximize the effectiveness of the treatment. Next, we have to place the patient in a comfortable sitting and about 30-degree position to ensure that the diaphragm, the lung compliance are greater in this position. And then add the prescribed amount of the medication and connect the tube to the compressor, and the funnels should be visible. And then place the mask on the patient's face to cover his mouth and nose, and instruct him to inhale deeply and slowly through mouth. Hold the breath and then exhale several times. And we have to observe the expansion of the chest to ascertain that the patient is taking a deep breath, and then instruct the patient to breathe slowly and deeply until all the medication is stabilized. And then, so it takes about 15 minutes duration. On the completion of the treatment, we encourage the patient to cough after several deep breaths. So the medication it may facilitate the expectoration of the secretion. Other than that, we have to observe patient for any adverse reaction of the treatment.
like the patient might develop bronchospasm due to the inhalation of the aerosol. So, and then we have to document the medication use in the to get a proper documentation, and this assemble and clean the nebulizer after its usage, and you have to wash the hand after that. So basically, the nebulizer have to be taken apart in separately, the 3 compartments, and the residual solution have to be discarded and washed with the warm soapy water and mild detergent, and rinse and dry with the paper towel. And the tubing and the chamber of the machine should be discarded if there is a discolored, stickiness, or chamber are cut. And the pump must be serviced every 6 to 12 months. I think that's all.
Any questions to the presenter? Let me highlight one thing. One thing peculiar, one thing interesting about nebulization. As mentioned, it uses Bernoulli principle. So the thing is, the faster the jet. So means the higher the flow, the more flow you use, the faster the jet, the velocity will be faster. And then the result is the aerosol particle will be smaller. So if you use a lower flow, the particles will be bigger. If you use higher flow, and then the particles will be much smaller. So smaller particles are easier, gets into the lung much better. It gets into the smaller airway. So that is why you want the smaller particles. So that is one thing. The next thing is, you need to remember, nebulization is an airway, is an aerosol generating procedure. It's an AGP, aerosol generating procedure. So in this COVID time, we know COVID is spread mainly by droplets. COVID mainly spreads by droplet. The problem is, if you have a child with COVID-19 and have wheezing, if you give nebulization, the COVID particles may actually, the virus may be spread through airborne. So COVID generally do not transmit by airborne, but if you do AGP, aerosol generating procedure, you will aerosolize the virus particles, and it may now become airborne and it may transmit. So that is why, especially in this era, for those children who are not confirmed to be negative for COVID-19, generally you do not want to use nebulizer. So we'll use aero chamber instead. So we'll use the metered dose inhaler with aero chamber. This is similar to what happened in 2009 during the H1N1 outbreak. So H1N1 influenza outbreak, this is the same thing that happened. So because H1N1 is also spread by droplets and also by airborne. So that is why we don't actually use nebulization. So the idea now, we try to go away from nebulization, unless for certain type of patients who basically with poor respiratory drive. So when they don't have good respiratory drive, if you give nebulizer, how can it get into the lung? So it can only get into the lung if the patient has good respiratory drive. Okay, all right, good. Any other question? Any other issue? Tak ada? Clear? Faham lah ke? Jelas?
Faham Doktor.
Terang lagi bersulur? Okay lah, alright. Good. Let's end here. Okay lah, alright. Your exam is next week. Kan? Okay, ready?
No, doktor.
Huh?
No, bukan next week.
In 3 weeks.
Oh. Alright. Okay. Let's end our session with tasbih kafarah and suratul Asr.